Good evening, everyone. We're going to get started for tonight. So I'd like to welcome you all to the Snyder Institute's Mini Medical School Lecture Series. We are pleased to host a presentation this evening on the topic of health misinformation. Before we get started, I'd like to go over a few housekeeping items. So there will be two parts to tonight's program. First, each of our presenters will speak for about 20 minutes, and then we will open the floor to audience Q&A. Following the Q&A session, there will be an informal reception for those of you here in person. You're welcome to ask your questions at any time during the presentations using Slido. To access Slido, you can scan the QR code or type www.slido.com into your browser and manually enter the event code SnyderMMS into the participant field to post your question. Questions submitted to Slido will be viewable to all audience members, and participants can upvote the questions they like the most. Now on to more specific housekeeping items. For those of you that have joined us online, if you lose your internet connection and drop out, you can return to this session using the same Zoom link you used to join us now. If you experience any technical issues, such as you cannot hear or see the presenters, please email snyder@buxa.com and our team will do their best to support you. For those of you here in person, we now ask that you switch your cell phone to silent mode. Please note that this event will be audio recorded and the recording will be posted on the Snyder Institute website and YouTube channel. Private recordings are not permitted. Now to formally begin tonight's program, the Snyder Institute at the University of Calgary's Cumming School of Medicine, located in the heart of southern Alberta, would like to acknowledge and pay tribute to the traditional territories of the peoples of Treaty 7, which include the Blackfoot Confederacy, comprised of the Siksika, the Piikani, and the Kainai First Nations, the Tsuut'ina First Nation, and the Stoney Nakoda, including the Chiniki, Bearspaw, and Goodstoney First Nations. The city of Calgary is also home to the Métis Nation of Alberta, Districts 5 and 6. Now, without further ado, I would like to introduce our first speaker, Dr. Craig Jenne, who's the Deputy Director of the Snyder Institute and faculty within the departments of Microbiology, Immunology, and Infectious Diseases and Critical Care Medicine at the University of Calgary. Dr. Jenne also holds the Jessie Boden Lloyd Professorship in Immunology Research. He's continuing his work using intravital microscopy to study the early innate immune response to viral and bacterial infections, the impact of vaccines on infectious diseases, and the interface between inflammation and coagulation. Welcome, Dr. Jenne.
Thank you, Hannah. Very excited, happy to be here tonight. I'm going to try and cover a little bit about misinformation in health, but I'm quite fortunate that I have Cora speaking right after me. So she's going to look after health, and I guess I'm in charge of spreading misinformation. I'm going to keep the science part really thin, and we're going to talk about misinformation in general and where it comes from, how to spot it, how to maybe deal with it, why is it a problem, things like that. And hopefully, we'll see, have a little fun, maybe, attempt some humor. Again, we'll see where we go tonight. So first, misinformation. You know, we've talked about this a lot recently, although it's arguably it's not a new problem. And you know, the reality is, ever since we've had information, we've had misinformation, and we can go as far back as we want. You know, let's see here. You know, people have misrepresented the truth ever since we've had knowledge or information, and the question has to be why. And when we look at the types of misinformation, I think we can really see a divide, and that is some misinformation is just simple error. I mean, we all make mistakes. We all forget our kids at school. I mean, I apologize. Sometimes it's misinterpretation of something and then amplification. So we think we understand it and we tell people what we thought of something, and that's taken as gospel. And you know, anybody who's played the telephone game knows how quickly that goes off the rails. We also have a significant percentage of misinformation comes from what we would term disruptors. These are people that have no interest in misleading you. They just want to watch everything burn, right? So they want to throw a seed of doubt somewhere and then just watch the chaos that ensues. We can move forward and now we start to see a little bit more of the intentional misinformation. We can see people that are trying to pass beliefs off as information without fact. And then finally, there is a significant number of people that are, in it for themselves, that if they can get you to believe something, they directly gain. And that could be financial, it could be political, it could be simply popularity. You have to be the most popular person in the room. I mean, often, as I said, it's innocent, and we can find those examples everywhere. So, in this particular one, today was rough in Florida, right? Monday, 887 degrees. I mean, you need SPF 4 billion probably to survive that. Or this happy couple, I mean, they look great for 600 years of marriage, right? You got to figure out what their secret is. So I highly doubt that this was a newspaper editor that goes, hey, watch this, right? I mean, this is simple misinformation. Unfortunately, that's not really what we're here today to talk about. We're often talking about maybe something a little less innocent. And recent studies have shown that over the last 8 to 10 years, that much of our misinformation is actually attributable to international players. And what I mean by that is that we can actually now track things such as Russian bots. So computer programs that simply interact with AI and put up false information. And what would be the reason of that? Do they really care if we don't vaccinate the flu? No, they're simply trying to sow distrust, confusion, argument, and keep us distracted from anything else they may want to talk about. Again, this is intentional, this is damaging, but in some ways it's somewhat random, and it's simply more of those disruptors. We do unfortunately have very clear evidence of something a little worse. And this is a very famous study that I'm sure most people would have heard of. This is a study that attempted to link measles, mumps, and rubella vaccines to autism. And this was published in the 90s, and it is since, this isn't my vindictive font on it. This is how you find the article now online. You cannot download it without the watermark that demonstrates it has been fully retracted. The author, for example, never had ethics to do his study. He pre-screened and handpicked children that fit his profile. And, ultimately, he also had a rival company he was trying to promote while taking down a different vaccine company. So anything that could go wrong with science went wrong in this one paper, but it continues to live online. And we've heard, even in the last year, conversations in the US FDA about what is the role of vaccines and autism, despite the fact we know that the paper that triggered this whole discussion has been completely fabricated. So the issue is the information is still out there and people continue to cite it. So as I said, this is not something new, but it seems to be something we're really dealing with in the last 15, 20 years, that it has risen to the problem of arguably a crisis. And in preparing for this, I've tried to sit back and say, how did we get to this point? How did we get to the point where misinformation is on a national level of something we need to deal with? And I tried to figure out where the problems are. So I don't think there's any one reason. I think it's actually a wonderfully horrific, perfect storm where multiple things have come together. And I've tried to group them, and I'll give a couple examples of each. But I think the problems with today's worlds are doctors, computers, and lanterns. And I'll try and, not all anyway, 1 second. So in the old days, i.e. when I was a kid, 30 years ago, I guess I wasn't a kid. Old days, when you had a question about health, you talked to your family doctor. I mean, this cheery gent is who I would get, reassurance that the vaccine was right for me. And reassurance was get the damn shot, you idiot. But we had those personal connections with somebody who was advocating for our health. The problem today is not everybody has a doctor, right? Recent data would suggest that 17 to 22% of Canadians and perhaps slightly higher percentage of Albertans do not have a family doctor. So who do they go to when they need help? they go to the internet, right? And this creates a big problem. In fact, a recent report by the Canadian Medical Association directly correlates lack of access to a doctor to the risk of being subject to misinformation. Right? So people who can talk to a doctor are less likely to believe misinformation than people who don't have a doctor that they can chat with. Hit number 2 is about computers. So again, when I was a kid, back in the 70s, 80s, to do research, you did this, right? Somebody peer reviewed these things. Somebody published these. Somebody had to put out money to get these out. Somebody had to update the card catalog. And if you're lucky enough to find a reference, then you got the joy, the absolute pleasure of one of these things, right? Microfiche, the original scroll left, scroll right, right? So for those that don't know, i.e. young people, you would find perhaps a newspaper or magazine in that paper card catalog that might have something that you're looking for. And you would pull out a little film that's on these 2 spools, and each film would have about 16 pages of a newspaper, really, really tiny. And you would zoom in on this little projector and read it on a screen. And for all the information you wanted to keep, you wrote it down. There was no screenshots, there was no downloads, there was no, right? So it did a good job of filtering out the junk information, but it also made you check your sources. You had to do the work. It wasn't right there at your fingertips. Spring ahead 20 years, this is what we have, right? So we don't have to look for it anymore. It is there. And in some ways, we can't avoid it. Numbers from Canada would suggest that more than 95% of Canadians have home internet and more than 93% have a cell phone. So nobody has to go and use a card catalog. And I don't even know if they make microfiche anymore. I mean, it's been a long time, but it changes our access to information, and it also changes the quality of information. Anybody with a computer can now put up a fact, and nobody is there to check it. And finally, the third big hit. If I can, for some reason, I'm failing to click. This is like double click at home. I'm really bad at it. Okay, there we go. Lanterns. We used to call this gaslighting. We now have a new term, like wonderful, somebody has given us all these wonderful new alternative facts. So gaslighting would be, you can convince somebody of an untruth by slowly working up to it. So you keep repeating your mistruth, your lie, your alternative fact until they start to believe it. And this is exactly what we have today, again, with internet, with broadcast news, with other things. The overwhelming amount of data, often from non-reputable sources, gets people to doubt what they know or believe to be true and persuades them to believe perhaps other things. Again, this term alternative fact, I mean, where it emerged is probably still the best example. So here we go. So by this fact, this crowd is record-breaking, and this was insignificant, right? And the alternative fact is that's true. And if you see it the other way, then you're wrong, right? If you think this is bigger than this, you're wrong, and we need to work on you, right? So this is what we used to call gaslighting. Today, we brand it as alternative facts. So we think they're facts, they're just not good ones. And perhaps the best definition I saw of it was this one. And I mean, I've asked my kids now for this for Christmas, right? Alternative fact, a lie. And I actually got into somebody about why can't we call these things lies? And apparently for a lie, you have to know you're wrong. And the individual who's claiming this, apparently we can't prove that they actually know they're wrong. So we can't call it a lie. So what we're left with is we're stuck really at this crossroads, right? When we see something, it's up to us now to determine if it's a fact or if it's fake. And this, again, is very problematic. I mean, just because it's on the internet doesn't make it true, right? Again, sometimes this is not intentional, right? Sometimes it is. So, this is a very famous newspaper, right? They called the US election early. Turns out Truman won. There's some really interesting backstory in this. They can't yet determine if this actually was intentional because the polls had not closed on the West Coast. So the new wire service got the newspaper headline to California while they were still voting and hoping to sway people to vote for the winner and perhaps swing the election. So for years in Canada, we've had a blackout that you couldn't release election results until polls closed. And that's based entirely on this newspaper. On the right, we've got this wonderful bit of, poor Bill, like it's one hell of a hook. And the fact that they have the alien picture, this is great. So not everything you read online is true. If there's anything we take away tonight, I'm hoping we already knew that, but anyway, sometimes information online though is misrepresented or sensationalized, and it gives it a different weight, right? So, front page of the Scottish Sun was mugged by a parrot. Thieving bird grabs Scots tourist 700-pound wad. Or we get into this one. I naked nutcase attacked florist with dead seagull. I couldn't make it up better myself, right? Doesn't mean they're wrong, although, yeah, doesn't mean they're wrong. It just maybe doesn't deserve front page. And then the other thing we have to keep in mind is knowledge does evolve, right? If we go back to the old days, and when I say old days, I mean older than me finally. We used to have cocaine toothache drops and asthma cigarettes and heroin and cough syrup with alcohol, cannabis, chloroform, and morphine. Literally called one night. No kidding. Yeah, 3-week-long night, that one. So just because it was real before, I don't know if they ever were. Just because they were something before doesn't mean they still are today. So with that, it does really raise a question about, given this horrific past history, why should we trust the system today? And I'd like to believe we've actually learned some things over the last century. For example, we have these guys now, which interesting looking building. I don't know, important people. But if we go back to the way drugs were approved before, prior to 1962, you just had to make an argument that your drug worked. That was it. That was all it took to get approved. We're not talking 1862, 1962. Your drug worked? Yep. Okay, here you go. Market your cigarettes for asthma. Now we have it a little different. So in 1962, there was legislation both in Canada and the US that you have to prove first your drug is safe, and then if it works. And more critically, we now have to have clinical data in people. You can't test it in a goldfish and say it's safe, right? It has to go through human trials. And then in 1987, we opened Health Canada, which is completely, we'll come back to it, arm's length from the government, makes independent decisions based on clinical trial data. So we've learned some lessons and we continue to improve the system. Now, one of the other problems, in addition to just making stuff up, is that not all facts, in quotes, are equal. And this is something we deal with a lot when we're talking to media, talking to public, that somebody saw one study somewhere that said vaccines cause autism, but they're ignoring literally the 49,000 other studies that looked at 7 million kids that say there's no effect, right? And we have to be careful that we don't give different data different weights, right? We have to look at where the wealth of information is. So again, personal suffering, misadventures, bad decisions. At a conference recently in California, and I searched for a 5-star rated bagel joint for breakfast. And up came my Yelp reviews, and I got this guy. Right? 5-star rating, technically 5-star rating. There seems to be a few more 1-star ratings. And when you dive into it, there was 16 5-star ratings by the owner, his wife, their son, and 193 1-star reviews. I opted to go somewhere else, but technically this met the requirement. This was a 5-star rated bagel joint. If you weight these two facts equally, which bad decisions in the past have taught me not to. right? So we have to look at the big picture. Often we'll hear people cite this notion of preprints. So these are scientific articles that are put out into a server or into a collection online for other scientists to help review and make comments. But the data themselves have not yet been peer reviewed. Right? So anybody can post a preprint. And they seem, for some reason, to carry the same weight as peer-reviewed published papers. And this is an unfortunate but clear example. So this is a Canadian group out of Ottawa that had published that if you got the mRNA vaccine and you were a young male, you had a 1 in 1,000 chance of swelling of the heart, which seemed to be out of sync with the rest of the world. The rest of the world was showing about 1 in 25 to 1 in 40,000 chances of this happening. And this was immediately seized by anti-vaxxers saying, see, we knew you were hiding the data, right? Leave it to the Canadians, they solved it. Within a matter of only a few weeks, this was withdrawn because the researchers actually found out they made a mathematical error. They divided by the wrong number. And this was caught at peer review. When this was sent to a journal with actual reviewers, they said, hey, this doesn't line up. And they caught it. But the preprint is still, people have downloaded it and it still circulates. Right? So this is a problem. We have to look at what is the weight of your information. You know, we've seen recently another story show up, right? You know, Tylenol, and which actually, when you watch the news release, it was bizarre. I mean, not surprised it's bizarre, but the individual in question, who shall remain nameless, although he's here, had actually said that the best evidence for this is if you look at circumcised babies. Because if you're circumcised, you have a higher rate of autism. And because of that, it proves Tylenol causes autism. And I mean, I need out a whiteboard to follow this argument, right? But his argument was, if you get circumcised, you're going to give your baby Tylenol and therefore they develop autism. And if your baby's not circumcised, they don't get Tylenol and they don't get autism. So giving your newborn Tylenol means we should ban it in pregnant people. And I said, what the hell was that? And yet Texas is now suing the maker of Tylenol. So no evidence, no clinical study, no anything, a microphone, a national media outlet, and we're going to probably see a bankrupt company here really soon. So how do we defend this? I mean, unfortunately, it's fake news is out there, right? I mean, this was out for years. Apparently 5 of these hang in golf courses. They're not real. He did it himself and put it up on the wall. And you know, it's not that hard to do. I mean, unless you look really closely. I mean, I'm an immunologist, not a virologist. Otherwise, perfectly acceptable, right? We have to be careful. It is getting near impossible to find fake from real. So how do we actually do that? How do we separate the wheat from the crap, right? And the hard part is it has become polarized, right? It seems to align with political belief, whether you're open to listen or not. And these trenches are getting deeper and deeper. So what are trusted sources? Where do Canadians go for trusted information? So I went and pulled the last few Leger surveys and got, absolutely depressed. Thank God the liquor cabinet was full. So Canadians' trust in medical scientists, peaked in the end of the first year of the pandemic at 83% and has now dropped to 73% as of 2023. We haven't seen the 2025 survey yet. They come every 2 years. Scientists peaked at a wonderful 77, and now we're down below 70% for trust. I mean, if these were exams, 73% is probably okay. C's get degrees. But is this really good? I mean, 1/4 of Canadians don't trust their doctor. I don't even know where you start with that. 1/3 of Canadians don't trust science. I mean, this makes a discussion of facts really, really difficult. So, if you don't trust this guy, who do you trust? Right? Where do people go if they don't trust their doctor? Well, thank goodness there's Dr. Google. right? Which is probably the worst thing you can do. I mean, unless you're alone in the woods on a sat phone, there's probably better choices, right? We know that Google or any of the AI answer questions only as well as the question itself is posed. So you can shape it. You can ask, what is the evidence linking mRNA vaccines and autism? You'll get one answer. Or what is up with mRNA vaccines and autism? You'll get a different answer, right? Google probably, although that's changing, may not have your full medical history. Again, probably will soon, which makes advice pretty tough, right? I mean, if it doesn't recognize you're a male and it says it's probably morning sickness, we've got some issues, right? It's often based on outdated information, or at least all information. Google doesn't have the ability to tell what's real and not real. So it's going to pull all the information. And we've seen before that there's definitely a confirmation bias, right? If you ask Google, do I have X? There's a better chance it's going to say, yep, you've got it. Goodbye, right? And we have to be careful of that. On top of that, there is an actual marketing bias with AI and Google and others. So I did, again, an experiment this morning. What is wrong with the Calgary Flames? And I mean, there was 72,000 pages of Google all the way out to 10 here, right? However, the important piece of this experiment was this, the little disclaimer that nobody ever sees on Google, right? The answer it gave you is personalized based on your search history. So if you've been looking up how to, bake salmon in the dishwasher, it's going to give you something a little different than where's the nearest burger joint. Right? The answer will depend on what you've been buying off Amazon, what you've Googled, what you've looked at. So there's a marketing bias when you use Dr. Google. So who else do we trust? Well, we got this group where every day we turn around, there's something weird happening, right? We've fired all of the people screening for avian influenza. We've stopped CDC reports. We've removed information about sexually transmitted diseases from web pages because we don't want to talk about that. Kids don't have sex. And, pull out of the World Health Organization, right? This is a problem. We can't even trust the US CDC anymore. We need to separate. I know this is, obvious, but and likely impossible. We need to separate politics from medicine. The good news is, again, in Canada, I mean, I can't speak for the US, but in Canada, Health Canada and PHAC are fully arm's length from the government, right? They're established, but they do not answer to the government. They are independent. So again, we can sort of trust our own people as opposed to looking internationally. When you see something, I mean, this is the advice now on how do you separate information. You got to check your sources, right? Is that paper, is that news article about a preprint, or is it about a peer-reviewed journal? Even if it's peer-reviewed, it doesn't necessarily mean it's great. We have this wonderful collection of what we call predatory journals. So if you pay enough, they will pay the peer reviewer for you. The good news is there's multiple sites. So this one is predatoryjournal.org that publicly out these people. So if you ever have a question about, the Southern Alabama Sheep Farmers Journal, you can check whether it's predatory or not. It helps reinforce whether the information you're seeing is good or bad. Ultimately, go from trusted sources. Again, in Canada, PHAC, Health Canada, NACI, the National Advisory Committee on Immunization. I've put in here Alberta Health Services. We have the Canadian Pediatric Society. These professional societies have policy statements, have recommendations, and are far more believable than when you Google open sources. So go to a trusted source, go to the source that your doctors go to, and trust the information that you find there. I mean, ultimately, it's never one thing, right? We need to get the rhetoric out of health information. Individuals have to be a little bit more active in checking your sources. Us in CSM, in Snyder, elsewhere, we have to be better, right? There's no argument that there is a lack of science communication, and we're partly at fault for that. But at the end of the day, when it comes to health information, talk to a doctor, right? In Alberta, we're very fortunate. We have 811. You can talk to a healthcare professional within minutes. and they'll set you straight, right? Don't go and Google what Trump's advice is on vaccines, right? Talk to your doctor, talk to a nurse, talk to a pharmacist. You'll get a much more believable answer. And ultimately, although we don't always get it right, science continues to evolve, learn, and correct itself. So, we have to trust the process. So with that, I'm happy to hand over and we'll hear a little bit more about real medicine.
Thanks, Dr. Jenne. That was great and very humorous. I would now like to introduce our next speaker, Dr. Cora Constantinescu, who is a pediatrician, infectious disease specialist, and clinical associate professor with the Cumming School of Medicine. With firsthand experience addressing vaccine hesitancy in the clinic at Alberta Children's Hospital, she's deeply committed to advancing vaccine research and education. Dr. Constantinescu specializes in developing and evaluating educational interventions grounded in behavioral change theory and applying these approaches to both healthcare worker and public vaccine education. In addition to her clinical and academic roles, Cora serves as co-chair of Immunize Canada, is a member of the Alberta Advisory Committee on Immunization, and holds the position of pediatric chair for AMMI Canada. She's a passionate and steadfast advocate for vaccination initiatives at both the local and national levels. Welcome, Dr. Constantinescu.
Thank you very much. It's really nice to be here. Good evening to y'all. I'm super short, so some of you may not see me past the screens, but I'll come around. Thank you for having me. Before I go on, I want to tell you a little bit about my disclosures. So I'm a co-investigator on a number of trials that have pharmaceutical support, GSK, Merck, and Pfizer. And all the money goes to the university, but we do enter into a contract with pharmaceutical companies, even when that does happen. I have personally received honoraria from the Canadian Research Network, the Federation of Canadian Women in Medicine, and for the Bridge Research Consortium. I sit on their advisory committee, and I've had honoraria from them. I've also done a lot of continuing medical education work that had been sponsored by pharmaceutical companies in the past. All the money goes into a university account, not to me, but again, I do enter into a contractual involvement with the pharmaceutical companies when that happens. So even though the money doesn't come to me, there is that relationship I wanted to share with you. So we just cannot talk about misinformation and not talk about vaccines, because really immunization and vaccines are misinformation's poster child. And that's not new. Misinformation around vaccines and the anti-vaccine sentiment has been there as long as vaccines have been there. So I love this picture here. This is a picture during the smallpox inoculation, during Jenner's trials and inoculation. And there was this belief at the time that because this came from cowpox and it was inoculated that way, it might turn people into cows. So this is actually what you see is these cows coming out. What I love is that Jenner is also portrayed as pretty cold and not feeling and not quite in touch with his patients in this picture here. And despite the fact that this is a really successful vaccination campaign, the one infectious disease that we have eradicated with vaccination, there is still misinformation around that and the anti-vaccine sentiment. And to some extent, it makes sense because we give it to healthy people. We give it to prevent something that may happen in the future. And it's really hard to calculate your personal gain from a vaccine. We can look at it at the level of the society. We can look at it in terms of the millions of dollars in lives that vaccines have saved. But it's hard when it comes to you thinking about what has the personal gain been for me around a vaccine. Vaccination has also had a bit of a dark past. So we know that we haven't always had no effects or even adverse events from vaccines. So for example, the RSV vaccine that was developed in the 1960s had 2 infant deaths. It actually had potentiation of disease in those who got immunized. So there is a lot to unpack when you think of vaccinology, when you think of vaccines, and when you think of the anti-vaccine sentiment. So what I'm hoping to do over the next bit is show you a little bit of where trust around vaccines is in the Canadian society, how we've come to be at this place, and maybe what we can do moving forward. I'm a pediatrician, therefore an eternal optimist, so I cannot help but think that not all is lost and there is still hope. And there are things that you can do within your own circles and within your own circles of influence that can actually change how people perceive vaccination and combat misinformation. Without a doubt, the pandemic has impacted our vaccine coverage. So we saw numbers like this worldwide. We saw that this was the largest sustained backslide in childhood immunization in over 30 years, that over the period of the pandemic, over a 2-year period, there were 48 million children didn't receive a single routine vaccine. This was known as a zero dose. So you can imagine that it was of no surprise when we knew that right before the pandemic, there were outbreaks for measles, for example, worldwide in 2018 and 2019, that people started worrying. And there were clearly interruptions in vaccine delivery. So we knew that even in Alberta, where we actually have a really robust immunization and vaccine delivery system, there were problems with resources, with access, people coming in to get their vaccines, diversion of public health resources to the pandemic. So a huge aspect of this had to do with access. Simply, people just could not access the same immunization services they had before. But we were starting to see something different as well. We were starting to see an attitude shift. And I would see it. We ran a vaccine hesitancy clinic at the Children's Hospital. I would see it in my interactions with patients. And I remember going to people and saying, I think there is an attitude shift. And people said, no, it's all has to do with access. We just have to improve access, which made a big difference. But it turns out that was not the whole story. So then when Angus Reid did the survey in 2024, February of 2024, and they looked, and these are Canadian data, these are Canadian parents that they asked questions to, and they said, think about your children, how do you feel about vaccinating them? Before the pandemic in 2019, and then after the pandemic in 2024, we saw vaccine hesitancy go from 8 to 16%, so it doubled, and vaccine refusers went from 4 to 17%, so increased 4 times. And without a doubt, the COVID vaccine, with the COVID-19 pandemic, the different public health measures, the vaccine mandates, made the COVID-19 a scapegoat for a lot of vaccine hesitancy. And what I would say now we're seeing is health and medicine hesitancy as a whole. So the perception of the importance of vaccines for children declined by 8.2 percentage points in Canada, and people under 35 were most likely to report less confidence about vaccines for children. And the reason that's scary is because that's the age group for parents. So therefore, it is no surprise that when you have a decreased uptake in vaccination and you have particularly low uptake pockets, infectious diseases like measles, which is an incredibly infectious agent, has found Canada. So that we saw, it started off in Ontario, we started seeing a significant measles outbreak, and then we saw the first child under 5 died after being hospitalized for measles from Public Health Ontario. And now, of course, as you all know, in Alberta, we're around just under 2,000 cases of measles, the largest measles outbreak our province has seen, and 153 people having been admitted with measles to hospital. And we've most recently, earlier this month, had our first measles death. So this is why this is panic-inducing to a lot of people, that ultimately attitude translates into behavior, and behavior means decreased uptake, and that means that we're going to have communities that are at higher risk of getting these diseases. So what's different now? For sure, the spread is so much faster and broader than ever before when it comes to misinformation. We know that people tend to be more sensitive to negative or vaccine risk content, the vaccine safe content. And to the point where the World Health Organization coined that phrase, the infodemic, that vaccine misinformation has spread on social media platforms at a rate that was so much higher than before. And when you actually read the study and you read other people's take on the study, you might have seen that the quote that misinformation on vaccines spreads 6 times faster than the truth around vaccines. And I would say that depending on the platform, it's even higher than that. And this all is happening at the same time as fact checking on a lot of social media platforms, and a lot of the typical kind of places where people get the news and information for is gone. So there is no accountability to what people put out and spread at a very fast pace. But the other big aspect of this is that not only do we have fast spread, but we have vaccines being now more politicized to the point where individual political stances dictate individual vaccine attitudes. And that is particularly concerning, because in some spheres, especially as we look and see what's going on in the US, misinformation is not just allowed, but it's actually encouraged, and it has become public policy. And I'll tell you what I mean about this. Sorry, I'm struggling with my many bits of, okay, so here, my many bits of technology. So what's really interesting is that now we have in the Trump administration high-level political appointees, including the NIH Secretary, the RFK Jr., who have recalibrated vaccination public policies to align with well-funded anti-vaccine organizations. So the Advisory Committee on Immunization Policy in the US, which was a very well-respected and known source of vaccine information and vaccination decisions, has actually completely been overhauled. So they used to have 17 people in the committee. They were all removed, and they're retracted and replaced with 11 new members, some of whom had actually been big critics of the vaccine policy before. So what that means is that now you have misinformation that is actually becoming policy. So most recently, the CDC came up with changes in vaccine scheduling and in splitting of vaccines without any new data that had been produced, but simply because now they were open to the same misinformation amplification that had been there before, and now it has become policy. And what's really interesting is this. Before all this, if you asked one of the AI platforms like ChatGPT to give you a little bit more about measles, mumps, rubella, varicella vaccine, it would give you a really nice comparison of the risk of the vaccination, risk of the disease. And now, if you ask it whether that vaccine should be split, it says yes, because it weighs information differently. So stuff that's already been taken up by the CDC is going to weigh a lot higher than the rest of the scientific information that hadn't changed at all around splitting this vaccine. And then from there, you have this. So you have, this is from Truth Social. This is quotes made by the American president about splitting, breaking up the MMR shot into 3 totally separate shots, taking the chickenpox shot separately, taking hepatitis B shot at the age of 12 or even older, and taking vaccines in 5 separate medical visits. So you can see how this kind of spread and this kind of misinformation has a very different impact on parents than before, because it's attractive. So to parents who are trying to make decisions around their children's vaccination, splitting vaccines, delaying vaccines, creating a sense of danger in vaccine, gives them actually, it's something they're easy to bite into, because it gives parents a sense of control when they can ask to split vaccines, gives them a false sense of time. So when you say delay, I can just wait, and communicates that safety is in inaction. So waiting everything is safer. All of which, of course, we know is not, because the way we put these vaccination decisions and schedules together have to do with when we think children are at highest risk of vaccine preventable diseases. So to give you an example of the hepatitis B vaccination that is now recommended in the US to wait till 12 years of age, is essentially saying, well, it's not a problem to, we have to wait for children to become sexually active or to do IV drug use or, to get involved in needle stick injuries, to get hepatitis B because it's spread via bodily fluids. Not taking into consideration that you can also get hepatitis B transmission from the mom to the baby. So that kind of waiting till the 12 years of age is fine if you have a universal screening program in pregnancy. But if you don't have that, then you're essentially allowing for vertical transmission from the mom to the baby, and forgetting that, I don't know how many of you have had children in daycare, that in daycare, bites are a rite of passage. So if you're the biter or the bitee, then you're essentially exposed to hepatitis B transmission, not looking after that. So these things seem safe to parents because they feel like, well, I can just wait. It makes sense. Kids are not sexually active. They're not going to get it, without looking at the whole picture and presenting the whole picture of, a vaccine preventable disease transmission to the children, to the parents. Because we know that vaccine hesitancy is really this distrustful complacency. So this interactive combination of low concern and low trust. So if you play on the low concern for the disease and you amplify the low trust for the vaccine, then you have shifted a balance when it comes to the decision making. So all of a sudden, this kind of information where you delay and split seems so reasonable for parents. And we know that, at least I know, because I see children admitted with vaccine preventable diseases in hospital, that it's never too late until it is. And this is from a campaign that we did around COVID-19 with a community organization called Praxis Health. So I'm telling you a bit of a sad story of how fast misinformation spreads and how now misinformation has become public policy for places like the CDC, which before were considered kind of the most go-to place for information around vaccines. And I'm worried about it because if you're not following this carefully, it's very hard as a healthcare provider to be able to tell of what is supposed to be the truth and what is not the truth. And it's even harder for the public who may not be, reading about this all the time. But as I said, I have to tell you the good news part of this whole story, and I love this quote by Martin Luther King Jr. It says, "We must accept finite disappointment, but never lose infinite hope." Because the one thing that was true before the pandemic and has stayed true post-pandemic is that healthcare workers are still the most trusted source of vaccine information. Now, we're less trusted than before, but a recommendation from the healthcare worker is still the most influential facilitator of vaccine behavior, which is actually really powerful and reassuring. Even though I still think that equipping our healthcare providers with the right information and the right tools is no easy task. But I'm lucky enough to work at a very trusted institution. I work at the Alberta Children's Hospital. We run a vaccine hesitancy clinic there. So we actually have been able to do quite a bit of work in this area and to understand how to support our families and our patients further. So during the pandemic, we were actually able to take our vaccine hesitant parents and learn from them what it is that might change their behavior. And this was around the COVID-19 vaccine, which, let me tell you, is the most contentious of all vaccines when it comes to vaccine hesitancy in parents. But this is what we learned. We learned that a positive interaction with healthcare provider influences behavior. So that is actually, you're like, well, duh, but it's actually not around vaccines. So people who've had a positive interaction when they showed up in the emergency department and it had nothing to do with vaccine, that interaction with their healthcare worker can influence the decision to vaccinate later on. So that means that as a healthcare worker, you actually don't have to know maybe a lot about vaccines. You just have to focus on that positive interaction with your patient, because that may be influential when it comes to their vaccination decision. We also learned that parents want to feel heard and have a trusted place to go to. And here's the part that I find really interesting, and I don't know how to operationalize this well enough. But parents did not trust the government and didn't trust public health at the time when we asked them questions, which was also really interesting. But they were more likely to trust the government decisions around vaccines if they saw frontline clinicians involved in those decisions. Because at the end of the day, you're going to trust the nurse and the pharmacist and the physician looking after you because you have a relationship with them in a way that you don't with maybe government or public health. And if those people could be seen as being involved in policy and governmental decisions, then that was going to increase the trust for parents who are vaccine hesitant. So we've taken it a bit of a step further, and we're now developing tools to support that healthcare workers and healthcare and allied staff around vaccine confidence information. So we now have a vaccine confidence toolkit. It's on the Department of Pediatrics website. It has different populations that we're hoping a healthcare worker can support. We have virtual simulation games. So we were trying to think outside the box on how to educate around vaccination and around fighting misinformation. And we're also focusing on debunking, and I'm hoping to start focusing on pre-bunking. I do that a lot clinically. So debunking essentially means you're correcting misinformation and you're trying to replace it with the truth. So they come to you with a concern and you're going to correct that. But pre-bunking is kind of like inoculating them against misinformation they may come across. So for example, a common one for me is that when I see patients talking about alternative health providers, I often will say, if you do use alternative health providers, keep in mind that often there is a tendency from them to recommend that you wait till about 2 years of age before immunizing your child. They're going to talk about the blood-brain barrier, and then we get to talk about that. So we kind of pre-bunk in anticipation of some of these concerns. I also want to direct you, and I know that Craig did a great job talking about some of the different agencies that are still very much trusted and put out really good vaccine information, but I did want to direct you to Immunize Canada, because there's a whole section that's not just for healthcare workers, but there's a whole section for the public, for parents, and also on how to communicate with peers around some vaccines. So this is actually a really great resource that I feel very, very privileged to have been part of and to still continue to work with. And then the Pan American Health Organization has come up with different guides on how to combat misinformation among policy managers, educators, and healthcare workers. So that's a really good resource as well. But I also want to maybe try and simplify all of that for like the next 2 slides, and then I'm going to be done, Hannah, in a little bit. How can you spot vaccine misinformation? So this is between the different resources I've looked at and what I've learned from my vaccine hesitant patients. This is how maybe a few things that should trigger that maybe this is misinformation on vaccines. If it's anecdotal or if it's based on just that one hit wonder study, that should give you a bit of pause. If it evokes a strong emotional response, that should also give you a bit of pause, because those are specific tools that are used by the anti-vaccine activists to actually have buy-in into the misinformation. And I also say when something evokes a very strong emotional response, regardless, you should take a bit of pause, because you're probably not your most rational self hoping to make health decisions. Worry about information that highlights vaccine risks and downplays disease severity. And that's over and over, and that's universal across all vaccine preventable diseases. The risk of the vaccine is just magnified, while the risk of the disease is really minimized. And then also worry about information that often tries to sell you something or has an alternative answer. So, the breakthrough solutions the scientists have hidden away from you, they've all collaborated together to keep away from the public. And this is the breakthrough solution. That again should give you pause, because scientists are never organized enough to actually come together and keep this kind of a secret from the public. But just so anecdotal or just a one study evokes that strong emotional response, highlights the risk of the vaccine and downplays the risk of the disease, and often tries to sell you something or provides an alternative explanation to all of it, should give you pause. And then I'm going to have this one slide, which is how do you respond to people who spread vaccine misinformation within your own circles? And I'm hoping that many of you will go from here and become vaccine advocates within your own circle, because our social influence circles are probably, I think this is the answer to fighting misinformation in the future. Because I tell you, as a parent, I take all my parenting advice from my fellow parents. We make decisions on everything that way. I often will go to my colleagues and be like, what do you do about this? And they give you something, I'm like, okay, I'll do it too. Like, we don't often go through a strong scientific critique of everything that we have to make choices over. So here are my three kind of overall approaches. So when you hear somebody spreading vaccine misinformation, try to find some common ground with them. If you have no common ground, don't bother. Just hold back, because there is just no way they're going to listen. And try not to correct something right away. So just work on that common ground. Try to connect before you're actually able to communicate with them. And you have to show true curiosity, truly, be interested in why it is that they are think that about a vaccine. And then you can't always validate what they tell you, but you can always validate the emotion. The most common thing that I come across in our vaccine hesitancy interactions is parents come and they say, my best friend, her child, they had a vaccine and they've never been the same. Or her kid can no longer do anything they could do before. I cannot validate that. It makes no scientific sense, but I can see the fear that that parent has around that. So I can validate the fear, the anxiety, the concern that they have, even though you cannot validate what they're saying. And I promise you, there's always some kind of fear that people come at. Unless they're professional anti-vaccine activists, most people are just really scared around a lot of this health decision. And then communicate to build trust. And when you do that, keep it super personal. Don't get into any kind of debates around vaccines. Just talk about the disease and what that might mean to that family or to that child. Or if you have nothing else, share with them why you choose to vaccinate or why you have chosen to vaccinate your child, because that's something that you can communicate to build trust. Last slide. Okay, I just cannot help but add a little bit of this into this. Do you know what the big friendly the BFG, what vaccine preventable disease is this related to? Does anybody know? Measles. And it's because Roald Dahl's daughter, Olivia, died of measles, and he dedicated the BFG to her. So I'm gonna finish with his letter, because this is now decades old and still so applicable. So this is a letter that he wrote to the Health Authority in 1988, advocating for vaccines. He said, Olivia, my eldest daughter, caught measles when she was 7 years old. And this was the 1960s, before they had a measles vaccine. As the illness took its usual course, I remember reading to her often in bed, not feeling particularly alarmed about it. Then one morning, when she was well on the road to recovery, I was sitting on her bed showing her how to fashion little animals out of colored pipe cleaners. And when it came to her turn to make one herself, I noticed her fingers and her mind were not working together, and she couldn't do anything. Are you feeling all right? I asked. I feel all sleepy, she said. In an hour, she was unconscious, and in 12 hours, she was dead. The measles had turned into a terrible thing called measles encephalitis, and there was nothing the doctors could do to save her. That was 24 years ago in 1962, but even now, if a child with measles happens to develop the same deadly reaction from measles as Olivia did, there would still be nothing the doctors could do to help her. On the other hand, there is today something that parents can do to make sure that this sort of tragedy does not happen to a child of theirs. They can insist that the child is immunized against measles. And what's striking about this, add the fact that I love Roald Dahl, and my kids have listened to all the books, is that not much has changed. We still don't have a treatment for measles, and we're still offering the measles vaccine as a way for prevention. Thank you very much.
Hi, everyone. My name is Derek McKay. Some of you may have met me the last time. I'm the director of the Snyder Institute. My pleasure is to be question master. So we'll have our two speakers come to the front. On a stand. We'll take questions from the audience and we'll alternate between the audience and what's coming online. I don't think we have a roving mic. Oh, we do have a roving microphone. We have two. So if there's questions, we can open it to the floor and then we'll see what pops up online. Maybe, oh, here we are, the gentleman here in purple. There you go.
You may have to repeat it online.
Yeah. Okay. Okay. Do you need me to repeat it, or they'll hear online the mic? They'll hear online.
Hi, this question I think is for Dr. Jenne. I'm wondering how much of misinformation is coming from a lack of understanding of statistical nuance when people are reading scientific papers. I see so often in the media that they'll report a statistic, usually a simple mean, and then they will take this as significant whether or not it is.
I guess.
Yeah, I guess.
No, it's a great question. I actually joke around with my immunology class that the one thing the pandemic revealed, or I guess two things, is one is the general public's actually pretty good at biology. They know the difference between RNA and DNA, but it also revealed we're absolutely awful at numbers. I mean, people have no idea about, especially if numbers are big. Like I'll often put up the actual stats of, for example, the risk of endocarditis, swelling of the heart muscle, if you're a young male and you get an RNA vaccine, is about 1 in 25 to 1 in 40,000. The risk of dying of COVID or getting heart inflammation from COVID is about 1 in 600 if you're a young male. So 40,000 from the vaccine or 600 if you get the virus. And we're dwelling on the one number because we don't realize 40,000 is bigger than, right? And those are smaller numbers. When we're talking about 50 million or billions, people just can't wrap their head around what 1 in a million looks like. And it's an absolute dead on point that we see the number, we panic about it, but we don't put it in context, whether there is error, whether it is statistically different, and how that compares to the other big numbers we don't understand.
Well, one from online, and I'll sort of paraphrase it. For either of our speakers, if the two opposing arguments are equally convincing and one is not true or less true than the other, how do you start to figure that out? I mean, if the speaker's very interactive, very positive, you come away thinking that's true, and then somebody else is equally. How do we start to think about that?
Yeah, that's particularly difficult because now a lot of people who, from a vaccine perspective, who were anti-vaccine activists now have the microphone. So they are actually invited to speak, to do lectures and to present on this, which is particularly scary. And a lot of them, you see, the thing about healthcare workers is we try very carefully to be very specific and correct in the numbers that we give. Whereas on the anti-vaccine side, they just throw numbers around and they throw data around in ways that we wouldn't dare to do on this end. What I say to people is this, first of all, it's easy to get excited and to buy into things. Sometimes, you get these Facebook ads, and I fall for them all the time. But then I think that what I've started to do, and maybe this would help you, is think, could they be wrong? And I've started doing that. I've started to think again. I've also read this book, Think Again, highly recommend. Could they be wrong? Could this be wrong? And you go back to those principles. Geesh, this is really emotionally triggering. Like this, I'm getting really into this. This is again downplays the disease, upplays the vaccine risk. This is not something that and then also look at the credentials of that person and what that person has been associated with before. And I think that makes a big difference to trying to go past just listening to the words and the message that they pass, and then taking that moment and say, could I have been wrong? Could this have been wrong? In when you hear that, I mean, Craig, is anything else?
I think it's also fair to ask, where did the facts come from? So somebody will take a position and they'll be very convincing about it, but what is that position based on? What information was used to come to the, and you can do it in a non-academic probing exam kind of way. It's like, it's an interesting point. Just, I'm wondering where did they see that happen? What led to that conclusion? And hopefully the person who's sort of more fact-based is a little deeper in that area. Well, we know from these studies and this properly placebo-controlled study that this is the answer, as opposed to, well, the guy on the bus told me that's what's happening, right? So I think once you challenge it, often those layers of confidence and persuasion can evaporate pretty quickly if they don't have actual studies, facts, or information to fall back on.
Question from the live audience versus the virtual audience. I'll do a very quick one, and maybe this is old hat to the audience. Craig, you're putting a lot of faith in peer review. What is peer review? How does it work? Why should I believe it?
Oh, so peer review is the arch nemesis of every scientist out there. Peer review is an exercise in professional trust. And what I mean by that is, whether it be a scientific discovery for publication or a research grant ask, or pretty much any academic output, we would then send those off to an evaluation panel of people who the author should be anonymous to, and the panel is anonymous to the author. And they're each asked to independently evaluate data, evaluate conclusions, evaluate statistical tests, and they will write an individual report. For example, for most papers, it'll be 3 reviewers. They're not allowed to talk to each other. They don't even know who each other are. These are done at their own pace. Reviews are sent back to an editor who compiles them into a list and sends them back to the author. Normally, reviewer 1 loves it. Reviewer 2's, reviewer 3 wants you to burn in. But we have to address those. And until all 3 reviewers are satisfied, the paper doesn't move forward. So this is where resources such as these predatory journal lists are actually pretty important, because journals will claim to be peer reviewed, but the review is not rigorous. The review is not critical. The journals charge a lot of money to publish your paper, and they choose reviewers who will be friendly. Journals that are not predatory, we have a pretty good faith, because we review the same way they review us. We need to be precise. We need to be accurate in order to advance the field. So we participate in this both as reviewers and reviewees. And we know that at the end of the day, stories that go out are at least supported by the facts. It doesn't mean they're right. It doesn't mean they won't evolve. It doesn't mean we won't discover something bigger, better soon. But at least the conclusions are supported by the scientific study at that time. And the whole basis of the research enterprise is on this. We put it out, reviewed by peers, published, and then we can challenge that in the next round of research.
Hey.
Yes, so if we review a lot, I still drive a used car. We don't get paid for reviews. Although if they want to pay me, I'm just saying.
And again, a lot of science is incremental. You keep building and building and building. There's very few massive breakthroughs that just happen overnight to change it. And that builds faith into the system, because other people repeat it, it's repeated again, it's repeated in different countries. So you build up that belief in your fact. Cora, I like this one, and it might be very hard to ask or to answer. You were giving tips as to how healthcare workers can build trust and overcome vaccine hesitancy about any procedure, doesn't be a vaccine. And someone online has asked, and this might help the audience to spread the news, what can the patient or the family member do to build that trust? Because healthcare workers, they're overworked, they're tired, they can be disgruntled. Are there things that you like to see from the patient family members that builds that trust as well?
Yeah, I just cannot say enough about this, about the power of peer influence. I just think that's so important. And I'll give you an example. Alberta this year does not have, there is a medication, an RSV immunoglobulin that is available throughout Canada except for BC, Alberta, and New Brunswick. They can be given to a newborn baby when they're in the first 72 hours of life to prevent severe RSV. And we don't have it this year. So if you are, because of all kinds of budgetary restraints and difficulties and the fact that, we have the shared responsibility around immunization between provincial governments and national governments. But if you're a grandparent, you're an amazing resource because you have more time, you can put time into this, you can write to your MLA, you can get together and be patient advocates because that's what we need. So I think the idea that even within your own, sphere of influence, if you can, if this is something that, you think might apply to you because maybe you have a new grandchild or a new baby or whatever, then I think there are things you can do within that circle. And I always say you can be a vaccine advocate or a science advocate within your circle as well. So, those principles we talked about before, you want to just have, build that common ground with somebody. Hopefully you already have it if they're within your peer group. Be truly validate the emotion behind their concerns and then share your experience and keep it personal and what you would do. I think that makes the world of difference. I've started doing it now all the time with my fellow parents. I said, hey, like, and I'll share this because this is a moment of intense pride for me as a mom and a vaccinator. My 14-year-old son went to the pharmacy and got the flu shot on his own. And I think, that's right. And I think that's like, I want to share that because that means that, and I said to him, you should share that within your teenage group. And he was like, oh, no. But I think we should share that because then it might make maybe somebody who is a peer of yours think twice about, but they were not going to do it this year.
Please go ahead up at the back.
I have a comment and I'm going to sneak a question in. I'm concerned in Alberta because you talked about the politicization of the anti-vaccine sentiment and other medical and misinformation in the US. I'm concerned we're living in that now. The lack of availability of the COVID-19 vaccine, the lack of access to it is worrying me. And I'm wondering if either of you, without putting you too much on the spot, but do you have any comments or any hope that maybe there's some science making its way around in the government circles? Thanks.
I'll take it. I'm glad you asked that question because it'd be very distressing if nobody asked that question or if people only ask that question anonymously. So thank you for asking it. I'm concerned too because I believe that no matter the government, what spectrum of the political, what side of the political spectrum they're on, I believe they want to save money. I believe they care about the economy, and I believe they care about their constituents, and I believe they care about what their constituents want. And I think at the end of the day, I think there is hope if we think about it that way. So I've spoken to some people about this, and I think what we need to do in terms of scientists and vaccine advocates is to position our arguments to see where that common ground is with the government. So I really do believe that the argument that COVID, influenza, RSV prevention means fewer wait times in emergency, means less strain on the healthcare system, means budgetary savings at the end of the day, is probably the more winning argument rather than just the science of the vaccines or, a sob story about one of my patients, which I can, there are many of those. I think we have to find that common ground with the government and continue. And I really do think, though, that this government probably listens to its base. And I think it's really important to get into those places and have people. I really think that having patient advocacy is what it's at with this government. So I really do believe that this is, again, you're not powerless. If you're not healthcare provider, I think you probably have way more power than, I've written letters to the Minister of Health. I've written letters to the MLA as a concerned citizen. I think you all should do about the things that matter to you because I believe by the end of the day, no matter where they are on that political spectrum. They have to care about budgets. They have to care about people. They have to care about the healthcare system. And we have to remind them that these are tools to help all of those things. So I think there is hope. I don't think there's ever no hope. I mean, if we say that, then that's it. We can't end it that way.
Yeah, and if one was cynical, you might think that the most number one agenda item for all governments is re-election. So the power lies there, right? So if you can, and as Cora was saying, when it comes from scientists or physicians, it's always seen as a little bit self-serving. But when the voting public, the patients, the family members step up, that can change things. So the power really is out there. There was one about medical schools and what is their responsibility. Will I handle that one? Yeah. It's a challenge. Many of our colleagues see things happening that we're not terribly happy about. So we are completely free as an individual to write and put our comments and sign group letters. It's really challenging for the medical school to do it as a single voice because it's part of the government funding policy and there could be wide repercussions. But we are certainly as individuals not held back from doing that, and letters have gone on a number of occasions to various MLAs and the government as well. So we try where we can. Other questions from the audience? Here we are, right in the front, please.
Okay. Hello. I just wanted to ask about if you guys could clarify on like how external funding does affect research, if at all, because like I'm aware that a lot of like the discussions surrounding vaccine hesitancy and distrust of researchers comes from people who look into like, oh, this scientist is like funded by this specific company, like you with Pfizer, for example, and they immediately have an opinion on that. Like as a student researcher, we do apply for external grants. And if my grant was based on the results of my work, I don't think I'd get the funding, but like I would like more clarification how that affects you guys personally.
No, I think that's a great question. I think it's probably also one of the, biggest elephants in the room, right? It is the number one argument that can be used against research, right? I mean, it's very, very difficult, if not impossible, to develop a new drug, a new vaccine, and test it without support from pharmaceutical companies. Right, for a new drug from discovery in the lab to on your pharmacist shelf is somewhere between $2 and $6 billion. When I write a grant to NSERC, Natural Sciences and Engineering Council, I get $75,000 a year. So $6 billion. I will be doing this job for the next 400 million years. So it's impossible. So we do have to partner, and Cora's gone through a number of her disclosures. I've in the past, not in the last 3 years, which is why I didn't have disclosures. I've worked with pharmaceutical companies, and as pointed out, there's contracts signed. And for example, I could speak to my own contracts that when I sign a contract, unfortunately, one is I receive no money, hence the used car in the parking lot. But I retain academic rights. So when we discover something, when we prove something, when we optimize a medicine, when the data goes back to the company, they're given a window, 6 weeks, 8 weeks, 11 weeks to intellectually protect the drug, the discovery, and then they can't stop me from publishing it. So if their drug causes little kids to grow tails, I'm going to tell people about it because I'll be famous. But they can't silence me. The contracts we sign allow us to retain independence and academic integrity so that we can control the data, and we're not subject to the company. The vast majority of money, for example, within the institution is what we would call external, but it's peer reviewed. So these are from granting agencies. And again, we submit a grant, it goes through a review process, money comes back. That money's paid to the institute, not to me, unfortunately, again, the car. But we are actually not policed. we are under very strict spending guidelines. So, if the lab wins $1 million grant for the next 5 years, we can't go out to dinner and celebrate. Well, we can, but it comes out of my pocket and not the grant, right? So we can only spend these on defined, restricted items. So again, we have to play by the rules, and those rules are designed to ensure that there's transparency. Any contract I do sign, there is a sunshine list. You can see wherever I've received money. And that list is not just money I receive as remediation. It is all the funding in my lab. So if a company gives money to my lab, that is on the list. It is publicly searchable. It is here at the UC. We fill it out every year. Again, thankfully this year it's a short form, no money, thanks. And but we try, we understand it. We understand the argument. So there is remarkable levels of clarity. It's just a matter of looking for them.
I'm also going to say that I think when it comes to clinical trials, so phase 3 trials and phase 2 trials around vaccines, they do come with pharmaceutical support. Again, it goes to the university doesn't pay my salary at all, ever. I don't also travel on any, I've been offered, but I haven't traveled on Pfizer's money or anything like that. I try to not do any of that. But I also want to point out that I have stayed away, anytime it had to do with hesitancy or communication or education, I have stayed away from any pharmaceutical money, even though often they'll give what they call unrestricted grants. So they give you a grant and you do whatever you want with it. It doesn't have to be their, product, or they don't influence your content. I've stayed away from that because of the optics, because it's hard to explain to people the nuances of this. So I've stayed away from that, but I think it's almost impossible to stay away when it comes to clinical trials, when it comes to phase 2, phase 3 vaccine trials, because they're incredibly expensive and they would just not happen unless these pharmaceutical companies supported their products, which they, at the end of the day. But I also would worry if that didn't happen and if they did that themselves and they didn't do it with academic institutions, because they don't actually control our methodology. They don't control any of the way things are done or the results are analyzed or how they're disseminated. So that is actually that academic integrity that would really worry me if that didn't happen, if the academic institutions and the pharmaceutical companies did not have that relationship, because then you'd have cause to worry if pharmaceuticals did their own trials in their own ways. But this way you have the academic institution that has the integrity to stay true to the scientific method and process. And I also want to highlight, because often this happens a lot in the US circles where they say, oh, pediatricians make so much money off of vaccines. We don't. We don't. I don't get paid to give a vaccine. I don't get paid to promote a vaccine. Nobody looks at my panel of patients and says how many of them are vaccinated. I don't get any bonus points for that. There's none of that going on, at least I don't know about every province, but there's none of that going on in Alberta. There's definitely none of that going on at the Alberta Children's Hospital. It has nothing to do with that. I don't, there's no extra money in my pocket in any way by advocating for vaccines for patients. But it's brought up all the time by people.
And I get paid less than that.
We'll be doing a whip around later for a new car for Craig.
Don't fund me.
So I'm sure there's more questions in the audience, lots of things online you can see. There's maybe a nice bullet point at the bottom. But in the interest of time, I'd like you to join me in two things. One, thanking your speakers tonight for taking time out and educating on this very important issue. And secondly, to join me out in the lobby here, we have some snacks and drinks and stuff. So please hang around, chat. The speakers will stay. There's some other of us. Have a nice evening, and I'll see you in a few minutes. Thanks so much for your attendance tonight.